Hey there, it's Justin Cook with the Critical Points crew, and I want to talk about ultrasound-guided IJ catheterization and cover the basics. I want to make you all expert in using ultrasound and putting in central lines, and the IJ is a great place to start. And some of the basics start with getting the probe orientation just right. So I don't care if you've done this a bunch of times or if you're a novice with this. One of the pitfalls I see frequently is people getting the probe reversed when they're doing a transverse approach or even a longitudinal approach to the IJ. So what I'm going to demonstrate with this helmet cam video in a second here is the sidedness of the probe and its correlation to its appearance on the screen. And what I'm talking about is when you look at most probes, there's a little nubbin on one side of the probe. And that nubbin often corresponds to that dot that we see usually on the left side of the screen. And you want to make sure those are matched up, because if they're reversed, then you get a symmetric reversal of the image you're supposed to see. And if you push the needle towards the left, you'll see it show up on the right, and it really doesn't help you guide the needle. In fact, it is misleading. So whether you're a pro or not, this is what I do. I touch the side of the probe and I look for artifact on the screen. So I see there's an indicator on the probe and that indicator on the screen, but when I touch that side of the probe, I see something on this side of the screen. So this side of the probe is giving me data on that side of the screen, and that will give me the anatomic relationship that I want. So before you do anything, make sure you got that covered. From there, we need to know a little bit about what this stuff that we're looking for looks like, how we can identify the IJ versus the carotid versus other structures. The IJ is generally thin-walled and it's compressible and often has this oval shape, and there's respiratory variation. So when you're looking at the IJ, it's a vessel that's dark on the inside, like all vessels, fluid being dark or hypoechoic. And when people take a breath in and they generate this negative intrathoracic pressure, that sucks blood into the chest, and so the IJ collapses to some degree. And that has some pretty dramatic variability depending on the patient's physiology. Then the carotid, conversely, is a more thick-walled vessel. Because of the thick wall and because of the pressures involved, it actually doesn't compress much when you push on the vessel, whereas if you push down on the probe on top of the IJ, a lot of times you can smush it down to nothing. And that actually becomes somewhat of a technical challenge when you're doing people who have these such incredibly compressible IJs. You don't want to push very hard on the skin because the target vessel you're trying to cannulate actually can be completely obliterated just with the weight of the probe. So being able to distinguish these two is really important, and there are a couple tricks you can use. One, compressibility, as I talked about. IJs are going to be compressible generally, and the carotid will not be. Have the patient bear down and generate some positive intrathoracic pressure, and that will blow up the IJ and will make it actually an easier target to hit around the time you're sticking the needle in. And then if you're really fancy, you can use Doppler. Sometimes that can be a little misleading, and I'll demonstrate that in a second, but if you're facile with ultrasound, I think Doppler can help you too. This is what you'll see in a transverse view, this oval-shaped IJ and a more round and thick-walled carotid. So to watch that video one more time, we'll just take another peek at that. IJ here and carotid there. And you see there's some variability in size just as you're scanning this vessel as opposed to this one, and that's respiratory variation, which in a longer video would be more apparent. As I mentioned, Doppler can be helpful sometimes. You'll see pulsatile flow here, but man, it almost looks like there's pulsatile flow in the IJ as well. And some people think, hey, well, if I'm using Doppler, the artery should show up red, and this one, because it's a vein, should show up blue. And really, that's not the case. It's not smart enough to do that. It basically is just giving you a color variance depending on the ability of the probe to detect where the flow is coming from and going. So, in fact, color differentiation is not that helpful, and I would discourage you from using Doppler until you get a little more skilled. The next step I do is I scan the entire target. Before I stick a needle in something, I want to know the trajectory I'm trying to head in. And before I get anything sterile, I want to know if the vessel I'm trying to cannulate is actually a reasonable target or if I should look somewhere else. So here's the next step. I start at the top of the neck, going transverse, and I scan down. This is my IJ. As I get to the base of the neck, it gets bigger. This is the case in most people. And as I come up, it gets smaller, and then it starts to bifurcate. Here's one branch and the other branch, and then I scan back down. Here's kind of a nice spot in the middle of the neck, and I think that's where most people go. This is some compression here. Notice the compressibility of the IJ, and the carotid doesn't compress. And so what I like about the mid-neck location is that you see that the carotid here is adjacent rather than deep to the IJ. And so when I went down to the base of the neck, there was a bigger target, but it's closer to the lung. So it's maybe a little less ideal to go sticking down closer to a target that might be adjacent to something I don't want to hit. The idea is you want to try and also get the IJ where there's not the potential for you to go deep and hit the carotid beneath it. So I look for an area where there's minimal overlap of the two vessels, even though I'm using ultrasound and hopefully able to visualize the needle tip the entire time. So I find this sweet spot. So I start superiorly in the neck, as I mentioned, rather stay away from the lung. I look for less overlap. Excuse me. The problem here is that the IJ may not be as big if I look higher in the neck than if I look towards the base of the neck. And one of the things that can affect this is how the respiratory variation in a given patient factors into this. So in other words, someone who has, say, bad COPD is going to have a lot of negative intrathoracic pressure when they're breathing. They're going to get a much more dynamic IJ, which is going to be harder to hit, and you may want a larger diameter IJ spot to go to. So here's an example of that. Here's a patient who I had who had bad COPD. He has a huge IJ that constricts down to nothing with breaths. And the other problem is there's a ton of overlap. His IJ is directly on top of the carotid. So this is a fairly challenging IV attempt in this patient. And it'd be best served by trying to maximize other factors, hydrate the patient, go closer to the base of the neck, and some other tips and tricks I'll show in a little bit.